department, and college name is College of Ayurveda Research Center Nigdi. So, Dr. Piyush, please share your slides. Dr. Piyush?
Yes, ma'am. Yes, ma'am.
Yeah.
Ma'am, there is a problem in sharing PPT.
Okay. So, I can share your PPT, no problem. Just
Yes, ma'am.
तुम्ही मला पाठवली आहे तुमची PPT?
Yes, ma'am. मी पाठवली आहे.
मॅडम नरेंद्र काळे जॉईन झाले.
Okay. So let's start with case. Is it visible to all?
Yes, ma'am.
Okay.
Good evening, everyone. All my respected teachers, university teachers. I'm explaining a case of dry cough, that is non-productive cough. I'm myself Dr. Piyush Pawar. I'm a PG scholar from College of Ayurveda and Research Center Nigdi. Here I'm presenting a case with a male patient, 56-year-old male patient, who came in our OPD with complaints of cough since 7 to 8 days, chest pain while coughing since 7 to 8 days, and generalized weakness since 7 to 8 days. Who has almost up to 8 to 10 cough bouts per day. Pain scale while coughing is 3 out of 10. That is VAS scale I am using here. For above complaints, the patient took private OPD medicines, but not relieved symptoms, so came for Ayurvedic medications. We done some examinations here. While first of all we did a respiratory which shows the mild expiratory wheezes in upper and middle lobe. The patient had history of consumption of cold food and drinks before up to 7 to 8 days. So he got cough and all these things. The chest percussion and all these things are normal. Then differential diagnosis. We thought it is a dry cough, that is Vataj kas in Ayurvedic terms. Patient has a shushk kas, that is dry cough, non-productive cough. Srinabala, that is generalized weakness. Urashula, like Urashula means coughing, chest pain while coughing, like classical Vataj kasa symptoms. Second is productive cough, which is absent because the cough was a non-productive, that is dry cough. TB, that is Rajexma. We thought about it, but the patient had without expectoration, and there is no weight loss or evening rise fever. The TB is absent. COPD, there might be chances of bronchial asthma, but not such as symptoms. So we thought about only dry cough, that is non-productive cough. Investigation, we did a lab which shows his HB is 14.4, WBC count is 4,720, platelet is 1,65,000, and with that we did a neutrophil count that is slightly raised, 83.9, and absolute eosinophilic count, that is 0.02 into 10 raised to 3. We did a chest X-ray which is in normal limits. So there is a slightly neutropenia in this patient. That's the chest X-ray, which shows it's normal totally. So in this case, we got a Ayurvedic line of treatment in this.
So I think it's enough for you. Thank you so much for your presentation. Now for expert opinion from modern medicine, we have Dr. Narendra Kane. He is Associate Professor from Department of Medicine, PCMC's PG Institute, YCM Hospital, Pimpri, Pune. Welcome, sir, Dr. Narendra Kane.
गणेश 2 अडॅप्टर घेऊन जा. तर रोहितला सांग हे डेलला कॉल लॉक करायचे अडॅप्टरचे. कॉल लॉक करायचे मला.
Okay, for next from Ayurveda expert opinion, we have Dr. Yogesh Kotangle. Dr. Yogesh Kotangle. He is Associate Professor, Kai Chikitsa Department, Sumati Vaishya Ayurved College, Hadaksar. Dr. Yogesh Kotangle, sir.
Yes, thank you, ma'am. Am I audible, ma'am?
Yeah, you
Am
are
I audible?
Yeah.
Yeah. Just a minute, I will share my some PPTs.
Okay.
Is my screen visible, ma'am?
No, sir.
Yeah, now. Hello.
हा सर, तुमचे पीपीटी अजून दिसत नाहीये.
दिसत नाहीये. Okay.
एकदा परत शेअर करा. तर पीपीटी आधी ओपन करून ठेवा आणि त्यानंतर परत खाली जो ग्रीन टॅब आहे शेअर स्क्रीनचा तो परत एकदा घ्या.
शेअर वरती केलंय मी पण ते होत नाहीये.
एकदा परत करा. नाहीतर मग माझ्या मेलवर पाठवा. muhs@ayush.ac.in.
जस्ट मिनिट मॅडम.
एकदा परत ट्राय करा आधी.
सर पीपीटी ओपन करून ठेवा आणि नंतर शेअर स्क्रीन वर जाऊन ते ग्रीन आयकॉन जे आहे ना त्याच्यावर जाऊन क्लिक करा आणि ती पीपीटी वर क्लिक करून शेअर मारा.
नाही, पीपीटी ओपन करून ठेवलंय मी तिथे आणि शेअर केल्यानंतर करतोय पण ते होत नाहीये.
काय येत आहे?
नाही मॅडम, मी तुम्हालाच पाठवतो. बेटर वे तुम्हालाच मी मेलवर पाठवतो. एकदा मेल सांगा मॅम.
MUHS नाही, सॉरी, ayush@MUHS.
जस्ट अ मिनिट. ayush@muhs.ac.in
AC.in
ना?
.ac.in. पाठवून द्या.
ओके ओके.
नेक्स्ट ओपिनियन घेऊया. We have Dr. Saili Kelkar. She is from DS Homeopathic Medical College, Pune. Practice of medicine is her subject, and she is assistant professor. Hello, ma'am.
Hello, ma'am. Thank you for this opportunity. Am I audible, ma'am? Is it fine?
Yeah, you are audible.
Okay. So, I have read the case which Pankaj has shared, Piyush has shared, sorry. In case of this dry non-productive cough, we should be first considering whether this, he has shared the acute case because the illness is from 7 to 8 days. In general, if we consider the approach for a dry cough, it has to be divided into acute, chronic, or acute or chronic conditions. Then causes should be respiratory, cardiac, and other causes. Prominently, according to the Piyush what he has shared, the causes are looking all respiratory causes. In these causes, we have to differentiate between allergic causes, infective causes. If there is any pressure caused because of some maybe tumor or any malignant tumor or something, if there is some irritant which is causing the such kind of reaction or the cough, something like smokers bronchitis or something like this, and even mechanical cause. I am talking about in general dry cough, not only related to this case. For the chronic, if this condition remains goes into a chronic stage, we have to consider the other steps for the evaluation. Anything else for the case do I have to tell you, ma'am? This was my general steps for the dry non-productive cough to be considered. And for Piyush's case, I want to ask 3 questions. Whether it's sure that the patient is not having any previous episode of the same complaint, so that we can rule out few illnesses. And was there any history of exposure to allergen? That I want to ask. For the Piyush's case.
Sorry, there is no history of exposure to allergen. Just he consumed cold drinks before 7 days, and after that he got.
Okay. And for the throat examination, what are the other things you observed when you were observing the upper respiratory examination for the nose, throat?
Ma'am, there is congestion in throat. There is throat congestion present, bilateral throat congestion, and we notice patches near throat, white patches near throat, suggestive of pharyngitis, you can say.
Okay. Carly, ma'am?
Ma'am, there is congestion in
Expert opinion. Now we have expert opinion from Dr. Yogesh Kothari, Ayurveda side. Is it visible?
Yes, ma'am. Am I audible, ma'am?
Yeah.
Yes. A nice presentation, Piyush, but it is very short presentation. According to Ayurveda, there is a Kshayayo Pekshita Sarve Balinashtoto Uttarottaram. According to Ayurveda, there are 5 types of kasa: Vatas, Pittas, Kaphas, Kshatas, and Kshayas. Vatas kas is the normal and primary cause, and Kshatas cause lead to be Rajakshama. The succeeding diseases mentioned are more serious than the preceding one, is the meaning of this Kshayayo Pekshita. etiological factors. Next, ma'am. Etiological factors like dhumopaghat, dust and smoke intake of less quantity of food, fasting, astringent, pungent and dry type of food, cold, guru, heavy, parvishit means stale type of food, Vishtambi food is the main etiological factor. As said by Piyusha, the patient has eaten cold drink previously. Maybe it may be the cause of etiological factor. Vegadharana, also Ayurveda told Vegadharan, that is a suppression of natural urges, is one of the major etiological factors. Daytime sleep, excessive physical stress, intake of curd or intake of cold water and beverages, traumatic conditions are the main etiological factors said by different acharyas. Next, ma'am. Diagnostic method as per Ayurveda, diagnosis is done clinically by sign and symptoms as per ancient test. The sign and symptoms are shushka kasa, that is continuous dry coughing. The patient is coughing continuously with excruciating pain in the chest. There is a dryness in the chest, excruciating pain in the epigastric region, flank region, and the head. There is also hoarseness of the voice with pain during talking, continuous attacks of coughing. Ma'am, next, ma'am, please. Next slide. Yes. Pain during talking, continuous attacks of coughing, resonance sound, also hollow sounds during the coughing. Patient may get tired. There is a symptom of weakness, fainting, agitated symptoms can also be seen. There is a Kshina Udasa is the one special symptom seen in the Ayurveda, that is reduction in the active component of all dhatus, that is fundamental element Oja dhatu. The patient feel better after expectoration. There is a scanty of phlegm after expectoration. Patient feel better. Kapha get elevated by the food, and after food digestion, again the coughing become increases. Patient desire to drink like snigdha, amla, lavana, ushna type of food. In the management side, the treatment told by Vagbhata and Acharya, Kevala Anilaja Kasav Snehai Adav Upacharita, means Snehan is the main treatment. In Vataja Kas, Vata is a type of dry cough. So Snehana in which there is a Ghutapan, Basti. Ghutapan means taking of ghee, enema, rice gruel, mugda soup, milk, meat soup with the Vatagna Dravyas is more important type of treatment in Vataja Kas. Also Abhanga, there is a Abhanga, Avaleha, Dhuma are some of the treatments taken during the treatment of Vataja Kas. In Ayurveda, there is one type of principle, that is Nidana Parivarjan. Whatever the cause may be, you can rule out the cause, and according to the cause, Nidana Parivarjan, avoid that causative factors. Til tel and sendo applications on chest is more comfortable for the patient. If it is associated with the constipation and flatulence, then Basti or enema treatment can be given to the patient. If it is associated with the aggravated pittas, then should be treated with the medicated Grita. And if there is association of Kapha, Snigdha Virechan. Actually, Vaman Virechan Basti is that one type of Panchakarma treatment can be used for the patient. Not only for the patient, but also normal condition, anyone can give Panchakarma treatment. Next one, ma'am. In the management, we can use different type of grutas, different type of grease like Guduchi, Kantakari, Pipali, Rasna, Chitrak, Agastya, Agastharitaki, Trushnadi Gruta. These type of various gritas used in the Vataja Kasa, as ghee is the main important content of the drug. Next, ma'am. There is some formulations like Sitobladi Churna with the honey. Vasa is again mucolytic derivatives of the alkaloid vaccine is also useful. Khadira, Takra, Pipali fried with the grutas and with the Sandava, it can be very useful in the treatment. Sandho, Pipali, Bharangi, Shringaber, Duralava, these are the Ayurvedic herbs normally used in our OPDs, routinely OPDs in the treatment for the treatment of the Vataja Kasa. Again, some remedies like Talisadi Churna with Sharkara, Katfal Churna, Yashti Madhu Churna, Lavangadi Vati. These are the routine drugs we can use for the treatment of the Vata Kasa. Next, ma'am. Dhoompana, it is the important treatment for the patient of Vata Kasa. Medicated smoke inhalation. Different type of Ayurvedic drugs like Ela, Maricha, Pippali, Suntha. These drugs used for the Dhumapana. Again, along with the Igundi, Bruhati, Kantakari, Karpas, and Kapus bolte usko, Karpas, Ashwagandha. These are the some remedies used for the Dhumapana conditions. Medicated smoke inhalation. Again, in Ayurveda, some treatments like अपुनर्व चिकित्सा. डिसीज फिर से नहीं होना चाहिए, इसलिए पेशेंट की इम्यूनिटी बढ़ाने के लिए अपुनर्व चिकित्सा इज सेड बाय डिफरेंट आचार्यज. दैट इज प्राणव स्त्रोत रसायन, रेजोनेटिव थेरेपी. प्राणायाम फॉर द चेस्ट के लिए बल आना चाहिए, इसलिए प्राणायाम थेरेपी. घृत वर्क एज एंटीऑक्सीडेंट, may reduces the airway inflammation. We can use also steam inhalation for the treatment of this type of vata. Next, ma'am. Some diet remedies. There is patya also advised by the different type of acharyas like mamsaras, meat soup, wheat, rice, yava. These are the routinely used in the diet. Kanji, that is fermented drink. Arishta and asa also used in the treatment. Patya. Grita tela can be used. Leha, different type of honeys. Shira, milk, guda, jaggeries. These are all remedies is useful in the treatment of the Vata Kasa disease. There are some limitations as when to refer. Prognosis. Vata Kasa is easily treatable disease. Is a very sadhya vyadhi. It is treated with the proper medications and diet. Untreated Kasa, that untreated coughing leading to different type of complications like swas, tamak swas or bronchial asthma, chardi, different type of vomitings, pratishay, swara beda. If it is progressed into Kshataja or Kshayaja cast like pneumonia or tuberculosis, we need to be refer for the further management along with the Ayurvedic treatment. Thank you, ma'am.
Thank you so much, sir. Thank you for etiology, investigations, signs and symptoms, then samprapti, chikitsa, and each and every aspect is covered from Ayurveda side. And see the beauty of Ayurveda, that is the previous slide, where it is apunarva chikitsa. And I think all drugs are routine drugs used in OPD. So
15 number slides, ma'am. Upon over 15 number slide.
Okay, 15 number slide. Okay, it's okay, no problem. Right. Apunarva chikitsa.
Yes.
Okay, so this is specialty of Ayurveda. Then for thank you so much, sir. Now next opinion on modern medicine, we have Dr. Narendra Kale. He is associate professor from BCMC PG Institute, YCM Hospital, Pune. Dr. Narendra Kale, are you available here? Yeah. Sir, please share your slides. If there is any problem, then you can share with me. I will share. Till that, sir will join soon. You can ask your queries to our experts, Dr. Kelkar and Dr. Kotangre, Piyush and other students. If there is any query regarding homeopath and Ayurveda treatment, you can directly ask to experts. सर केलं का शेअर करा ना प्लीज. नाव सांगा मला कुठल्या याच्यातनं केलंय. नाही नाही म्हणजे ते इथे कुठलं नाव येत आहे मग तुम्हाला आम्हाला पोस्ट करू आम्ही तुम्हाला कुठल्या नावाने प्रेझेंट करताय म्हणजे मग मला कळेल. लेंडे सर कंप्यूटर सेक्शन. हॅलो. There is some technical issue. Sir will join shortly. Till then, if you have any query regarding dry cough or non-productive cough, we can ask to our experts. So Dr. Narendra Kale is here. Welcome, sir.
Hello.
Yes, sir, you are audible.
Am I audible?
Yes, sir.
Okay.
Sir, you can present orally.
Yes, madam. I'm starting my presentation. I'm trying to sharing it.
Audience, you can say your feedbacks or what to be taken next topic, your suggestion, you can write it.
Is
Chat
it
box.
visible now?
Yeah, sir, your PPT is visible now.
Yeah.
So,
Okay. So I will start my presentation, madam.
yes,
If invisible in between, let me know.
yes, sir.
Myself, Dr. Narendra Kale, Associate Professor, Department of Medicine, PCM6 PGI YCM Hospital, Pimpri. I have heard that case presentation, but that case history was not so much long. So in my presentation, I have included the points also which to be covered in the history. Okay. So regarding this first part, I will just skip it. I will come into the main parts. Dry cough, what are the etiology, diagnosis, treatment guideline, and when to refer patient. So types already told that if it is acute, it shall be less than 3 weeks duration, subacute 3 to 8 weeks of duration, and chronic more than 8 weeks of duration. Whatever cough we are coming across, mostly bacterial and viral, usually they are less than 3 weeks duration and self-limiting. And these types can also be classified based on the system, respiratory or non-respiratory, based on etiology, infectious and non-infectious, and based on the cough, productive or non-productive. We'll focus on a dry cough mostly. So it is a cough that does not produce any expectoration, and it is usually chronic, and 40 to 46% of the patient with dry cough has an unexplained etiology. Means how we cannot find the etiology even after all the workup. Regarding causes of dry cough, there is a huge list of causes of dry cough, respiratory and non-respiratory. In the respiratory, common causes are post-nasal drip, post-infectious like COVID-19 and other viral infections. Then asthma, these are common causes. Other respiratory causes, bronchiectasis, bronchitis, COPD, cystic fibrosis, lung interstitial lung disease, primary, secondary lung tumor, sarcoidosis, tuberculosis, and other fibrosis. Then other conditions like chronic tonsillar enlargement, obstructive sleep apnea, chronic snoring, irritation of the external auditory meatus, laryngeal problem, foreign bodies in the large airways. Non-respiratory causes, common causes are the GRD and recurrent aspiration. Other systemic causes include cardiac causes like left ventricular failure, mitral stenosis, pulmonary infarction, psychogenic cough, rarely cardiac arrhythmias and aortic aneurysm also can cause this cough, dry cough. Environmental causes, smoking, active and passive both. Then particulate matter of 10 micrometer or less, occupational exposure to irritants, drugs like ACE inhibitors, beta blockers and NSAID, drugs that causes pulmonary fibrosis like bleomycin, busulfan, methotrexate, carmestive, amiodarone, cyclophosphamide, hydralazine. Other very rare causes, cough occurs when the wound supine due to the collapse of the large airways following a complex involuntary tics like Tourette syndrome, and sometimes vitamin B12 deficiency also due to sensory neuropathy can cause a dry cough. Most common causes in the respiratory is a post-viral infection of upper respiratory tract, post-nasal drip, cough variant asthma, eosinophilic bronchitis, mediastinal tumors, pleural disease, and early interstitial fibrosis. In non-respiratory, common causes are gastroesophageal reflux and ACE inhibitor induced, then psychogenic and idiopathic. Of all these causes, we have to remember these three most common causes are the cough variant asthma, GRD, and UAC, that is upper airway cough syndrome. This is a pathogenic triad and it constitutes 90% of cases. And apart from that, new terminology as is fourth etiology, it is non-asthmatic eosinophilic bronchitis. It has been recommended by the American Thoracic Association. Then regarding causes in the detail, upper airway cough syndrome, also known as post-nasal drip syndrome. This term upper airway cough syndrome is given by the American College of Chest Physicians, and usually this is due to the irritation and inflammation of the upper airway structures that stimulate the cough receptor independently or in addition to the post-nasal drip. Clinically, patient will have a sensation of something draining into the throat or need to clear his throat all the time, tickling sensation in the throat, and sometimes there is a nasal discharge, but mostly it is a dry and cobalt-stone appearance of the oral pharyngeal mucosa if you do a pharyngeal examination. Patient may have hoarseness of voice, wheezes, and other history of upper respiratory illness. In atypically, presentations are often there, but usually they respond to the empirical treatment. And use of intranasal corticosteroid in some cases is needed. It has to be limited. And oral antihistamine is also recommended in some times. nasal ipratime bromide is recommended in patients with rhinitis. Cough variant asthma, this is a new term regarding cough variant asthma. Patient present only with cough and that is also dry. Usually it is nocturnal cough and it is a high sensitive cough reflex. So other symptoms of asthma may not be present in this case. Other symptoms, common symptoms like wheezing and breathlessness may not be present. Just patient present with cough, but if you go in the details of the history, patient may have any trigger factor history or history of asthma. So regarding diagnosis of asthma, it is always by spirometry or special test like methicillin test, and management. Avoid trigger factor like allergen or allergens, beta-2 agonist, leukotriene receptor antagonist, inhale corticosteroids, and in very rare cases, small burst of corticosteroids for 1 to 3 weeks. Another most common cause is gastroesophageal reflux disease, and it is very common condition, almost accounting for 40% of the patient, and it is due to the reflux of acid, usually postprandial cases, and there is three mechanisms. Intraesophageal reflux occurs by stimulation of the esophageal tracheobronchial cough reflex, then laryngobronchial reflex, and microaspiration. So these act directly as a triggering event for the cough, and these are vagally mediated. Then ACE inhibitor cough. So cough due to the ACE inhibitor is a dry persistent cough, and usually if you take the history of medication history, then you can see that there is history of patient taking captopril or enalapril. Mechanism is due to the accumulation of bradykinin and substance P accumulation in the upper respiratory tract, and which is otherwise degraded by the ACE. And incidence range from 5 to 35% among the patients treated. And onset, if you start ACE inhibitor, it can start within hours of first dose to the months of the initiation of therapy. And resolutions occur within 1 to 4 weeks of cessation of therapy. And that is the only effective treatment. So you have to stop ACE inhibitor and switch on to the other antihypertensive agents. And incidence of cough associated with therapy with angiotensin inhibitor is similar to that of with the control drugs. Interstitial lung disease also initially present as a dry cough. So only symptoms in the beginning as a dry cough. So all the patients with interstitial lung disease, we have to be very watchful that they present with dry cough, and it occurs due to the inflammation of the interstitial due to the various cytokines, and it is almost seen in 80 to 90% of the interstitial lung disease patients, and it occurs in early. Regarding history part, we have to take history of fever, weight loss, night sweats, and progressive fatigueness has to be inquired. So it can suggest a tuberculosis or like chronic illness or CA lung related illness. In general examination, do not miss clubbing, which is a sign and symptom of vasculitis, sarcoidosis, malignancy. Do not miss pedal edema and lipidopathy. You have to always examine these three things. Apart from our vitals, physical examination, always examine dilated nasal, hypertrophy, polyps, and sinusitis, and also examination of ears. So regarding clinical case presentation, we also miss this examination of the ear. So examination of the ear, then upper respiratory tract, it is mostly missed by all the students, so it has to be remembered always. In the respiratory system, patient may present with bilateral wheeze, and localized wheeze may be there due to the obstruction or foreign body or tumor. So in all these cases, chest X-ray is mandatory, and if you see if chest X-ray is normal, then it is mostly due to the three causes: ACE inhibitor therapy, postnasal drip, GRD, or asthma. 4 causes, and it accounts for the 90% of the cases. And diseases causing chronic cough but missed on the chest X-ray includes tumors, early ILD, bronchitis, atypical mycobacterial pulmonary infections. So history part is very important in any case history. So I have seen that the students presented with very short history. Then Further investigations, sputum investigation, examination, cytological examination. In blood investigation, important things is CBC and eosinophil count, ESR, CRP, malignancy and connective tissue disorders. Serological tests like HIV, ELISA, cold agglutinin for mycoplasma pneumonia in rare cases. If you are suspecting Bordetella pertussis, then nasopharyngeal secretions, then induced sputum analysis, bronchial provocation test with methacholine for asthma. Bronchoscopy is to be done after excluding all the common causes. And if foreign body inhalation is suspected, then only do a bronchoscopy. So there are specific indications for the bronchoscopy, and one is abnormal chest X-ray and you are not finding any cause, and hemoptysis, patient is having recurrent hemoptysis and blood loss, obstructive lesions and infiltrates otherwise cannot be evaluated by any other diagnosis. 2D echocardiography to evaluate causes related to the right heart failure and left heart failure. Then 24-hour ambulatory esophageal pH for GRD and manometry for the GRD. In the management part, mostly you have to find out the cause of the cough, and if cause is found out, then you have to treat the cause. So how to approach these cases? If there is a chronic case present and you have a clinical history, and investigate and treat, but see that if there is inadequate response to optimal treatment, suppose antibiotic course is for 5 days and you have given only for 2 days, that may be an inadequate response to optimal treatment. So you have to use this treatment properly. Then if history and examination, if you done a case X-ray and if there is no cause, then all this cause already told by me, that is the upper airway respiratory syndrome, that is the postnasal drip is there, then asthma, non-asthmatic eosinophilic bronchitis and GRD. And if cause is not found out, then we have to further evaluate. In the management, non-pharmacological management like curve suppression therapy, life modification and lifestyle modification include most of the other things, include education, behavior, speech, laryngeal hygiene, hydration, breathing exercise and counseling. In pharmacological management for dry cough is anti-tussive therapy and adjuvant are the antihistaminic therapy. Specific treatment approaches based on the causes, they are already known, but specifically upper and lower respiratory tract infection, appropriate antibiotics. Pulmonary tuberculosis, you have to give antitubercular drugs. Asthmatic patients, you have to give inhaled beta-2 agonist or steroid or ipratropium, and in combinations. In pulmonary eosinophil, you give DEC or inhaled corticosteroids. Post-nasal drips, you have to avoid precipitating factors and corticosteroid nasal spray and H1 antihistamines. GRD, aid elevations, light dinner, diet modification, H2 blockers, proton pump inhibitor, mozaprides like kinetic drugs. ACE inhibitor associated cough, you have to substitute with other drugs. Post-viral cough, usually no specific treatment is required unless it is chronic. So regarding center and act peripherally in the respiratory tract or both these actions. Anti-tussive should be used only if there is a dry non-productive cough, or if the cough is unduly tiring and disturbs sleep and is very hazardous, especially hernia, piles. So in these cases, you have to judiciously use the anti-tussive. In the opioid anti-tissues, and in non-opioid
Computer section, please take care.
In the codeine, you have to remember the side effects like nausea, vomiting, constipation. Constipation is the major side effect of the use of codeine, and it has to be judiciously used, and it has to be contraindicated in asthmatics and in patients with diminished respiratory reserve. Similar thing with the dextromethorphan also. then it has to be there is a less incidence of constipation, but you have to avoid use in children. Then peripherally acting agents like demethylsons, they are useful for cough originating at the level of the larynx, and they form a protective coating over the irritating pharyngeal mucosa, and they are usually given as syrups or lozenges. That includes acacia, licorice, glycerin, honey, and wild cherry syrups. Then local anesthetics are also used. These are used mostly in bronchoscopy, but in ICU setup on ventilator patients, they are also used as a local therapy. If you see the steroids mostly used as a local inhalational drug, budesonide and fluticasone, and oral use is very restricted to very few cases, and it has to be restricted to 1 to 3 weeks short burst cycles. Prednisolone 0.5 to 1 milligram per kg dose, and you have to give 1 to 2 weeks and then taper. And in short, if you see the curve, less than 3 week duration usually is a viral or bacterial infection, and you have to give supportive antibiotics. And 3 to 8 weeks it is post-viral, and in this case pertussis also comes in the 3 to 8 weeks, as it is also called as a 100 days fever. And in more than 8 weeks in chronic conditions, you have to evaluate. If it is more than 8 weeks, chest X-ray is compulsory. Chest X-ray is normal, then think of 4 causes: bronchial asthma, drug-induced cough, ACE inhibitor, and post-nasal drip, and GID. If it is abnormal, then think of common things first, like tuberculosis, COPD, then ILD, CA lung, and bronchiectasis. And if you cannot evaluate regarding, or you cannot find the cause, then you have to go for the further CT scan and other investigation. So, whom to refer and when to refer? There are red flag symptoms like copious sputums is there, like in bronchiectasis. Patient is having hemoptysis, malignancy, tuberculosis may be there. Systemic symptoms in tuberculosis, lymphoma, and lung, primary, secondary, and significant dyspnea, mainly cardiac causes, or obstructive airway disease and fibrotic lung diseases. So in this case, you have to refer to the specialists like pulmonologist, ENT surgeon, medical gastroenterologist, or immunologist, or allergist, and neurologist. These are the, you have to refer to the specialist. So what are important symptoms you have to look for? If adult comes with more than 2 weeks, coughing at night, or underlying having a chronic disease, sputum with blood or brown, yellow, and green, aspiration and of foreign objects, and cough persisting as an adverse effect, then you should refer them directly to the specialist, and do not try to give them some antibiotic and follow for 2-3 days. These patients you have to refer to the specialist, or try to refer to the ICU hospital as early as possible. Thank you, madam.
Thank you so much, sir, for detailed description of cough. And some slides are most important. I think that second last slide, when to refer. It is the most important slide for all of us. There are the red flag signs in that slide. So that one. And next is, sir, there is one sentence in your slide that X-rays are mandatory in each and every case. So
no. Each and every case means usually it has to be done if a cough is more than 3 weeks. Then each case has to be X-ray
if
done.
cough is more than 3 weeks, then X-ray is
Not
mandatory.
short term.
Okay.
Yes.
Thank you. So, is there any query from students or participants, other participants? Nowadays, it is the most prevalent condition, seasonal cough. In OPD, we are facing many patients of dry cough. So, if there is any query, you can ask directly to our experts. Okay, so I think there is enough description, so no queries at all. Thank you so much to all the experts. Thanks to our PG, Dr. Piyush Kumar, Dr. Thanks to all experts from Modern, Dr. Narendra Kale, Yogesh Kotare, from Homeopathic, Dr. Saili Kirkar. Thank you again. Thanks to all participants.
Thank you, ma'am.
Thank you, madam.